Thank you so much, Ivan. I really appreciate that. And I also want to say thanks to Lynn Braziz for the invitation. Charlie Ornstein, thank you so much. Before I get started, I just want to shout out to my friends from RAND. I'm on the RAND Medical Advisory Board. I also want to acknowledge my friends at Emory University, where I'm on the faculty. I do have a new book out. It's called How We Do Harm. There will be copies available in right after the talk. It will serve as sort of the handout for my talk. I have been worried about journalism for a long time. About a year ago, I wrote an op-ed on CNN.com about my concerns about healthcare journalism and how you guys are under siege. We're not being appreciated by newspapers. Newspapers themselves are in trouble. And I would just want to say, after seeing those awards today and hearing those titles, I'm thrilled. I mean, you guys have been under siege, but you're still doing a great job, and I really appreciate that. And I appreciate that because truly I think we need to be talking not about reforming healthcare. We need to be talking about transforming healthcare. And the key to transforming healthcare is actually through you guys. It's through educating the public. It's through making people aware of what's actually going on. And those awards that I heard today really were wonderful pieces of journalism that do exactly that, make people aware of what's going on. Now, I am a oncologist, a medical oncologist and an epidemiologist. I still practice over at Emory University Hospital, although I prefer to do most of my work at Grady Memorial Hospital, which is about 8 blocks down the way here. And I spend a lot of time as chief medical officer at the American Cancer Society worried about where trends are going and what's happening and trying to make sure that people actually focus on relevant and pertinent things. So the first thing I'm going to say is always keep in mind that the leading cause of cancer and indeed the leading cause of heart disease is tobacco usage. Also, please keep in mind that the second leading cause of cancer is the combination of very little physical activity, bad diet, which usually means high caloric intake, and obesity. The three-legged stool, or that triad, has become the second leading cause of cancer. It's also the leading cause of diabetes and a leading cause of heart disease and a leading cause of orthopedic injury. And the rest of my talk is going to be very much about what's going on in medicine. Those things, smoking, obesity, bad diet, and lack of physical activity, and the growth of the population, the fact that the number of people over the age of 65 is going to double over the next 20 years, that's what's going to bankrupt America. We keep talking about the Commerce Clause and other things and political. That's the threat to commerce right there. The fact that we are increasing our health care costs. Keep in mind, by the way, I think some of you have written about this. I know some of you have written about this. Healthcare is currently 18% of our gross domestic product. At current rates of growth, it's going to be 25% by 2020. At some point in time, healthcare is going to so dominate commerce and to so dominate costs in the United States, so dominate our economy, it's going to cause our economy to collapse. What we've gone through in the last couple of years is going to be nothing compared to what we will go through when health care is 25 to 30% of every dollar spent in the United States. And that's only going to be in the next 10 to 15 years. Now, a little bit about me and my philosophy and why we have to approach these things in a very scientific, rigorous way. I am conservative about one thing, and that's the application of science, the application of science to medicine. And perhaps part of it is because of how I grew up, and part of it is because I've seen people be harmed over the misapplication of science and medicine. I grew up in Detroit in a neighborhood that I don't think many of you would want to go for a walk in. I had a group of wise but uneducated adults around me helping bring me up, my parents among them. They had all fled the South in the great northern migration of the mid-20th century, trying to find a better life in the industrialized North. I was very fortunate that they encouraged me to dream and that they actually told me that I could achieve, and actually when I doubted whether I could do something, I was scolded for doubting. They also exposed me to the Jesuits, which gave me a certain amount of cynicism, which I carry to this day. Yes, I am a victim of the Catholic schools in a good way, I think. Those same folks who actually encouraged me to go into medicine, and indeed worked hard to pay for me to go into medicine, were people who were very suspicious of medicine. They actually thought that doctors were frequently out to make a buck. They actually thought frequently doctors didn't know what the hell they were talking about and were making it up as they were going along. I questioned their wisdom as I went through medical school, and then I wrote this book 25 years after graduating from medical school, and I concluded that a lot of doctors are out to make a buck, and a lot of doctors are out making it up as they go along. We have an amazing healthcare system, or I should say a healthcare system with amazing potential that it is not meeting. There are tremendous flaws, inconsistencies, and inequities. When we had the conversation about healthcare reform, I can remember some of the politicians talking about how great our healthcare system is, and I was thinking, gee, we're 50th in life expectancy. We're 47th in infant mortality rate. Countries such as Cuba do better than the United States in those measures. I was also thinking that this whole conversation about healthcare reform seemed to lack a human element. The people who I saw at Grady Hospital, the people who I grew up with, those folks were not talked about. Indeed, the whole discussion about healthcare and healthcare reform seemed to lack the fact that there were people out there suffering and there are people out there dying. And then, of course, some of those who know me know that there's a certain military side of me, and I had to get involved in this thing called the Surge about 2 years ago. And in their wisdom, the Navy put me out on a ship with a bunch of Marines and a troop carrier. And as we left the ship every day to go do whatever we were doing, I was in the South Pacific having fun during the Surge, so no action for me. But as we left the ship every day, there was this sign that we passed under. We are Americans, we leave no one behind. And I already started working on this book, and I started realizing that we are Americans and we leave a lot of people behind in our healthcare system. These flaws and these inconsistencies. Thank you. Indeed, healthcare today is a subtle form of corruption. There really is a subtle form of corruption in American healthcare. Who's at fault for this corruption? Quite honestly, it's the doctors, it's the hospitals, it's the hospital systems, it's the insurers, it's the drug companies, it's the lawyers, and it's even the patients. Everybody is at fault for the fact that there is this subtle form of corruption in American healthcare. Everyone is at fault for the fact that the system really is not failing. Quite honestly, failure is the system. We have doctors who want money. We have companies that want money. They give, those doctors give unnecessary chemotherapy in my business. Those doctors give unnecessary surgeries and treatments, unnecessary imaging. They make promises about screening tests that we don't know. Then we have patients who consume too much health care, patients who want things. We have patient families who are unable to accept the fact that their comatose father with stage 4 widely metastatic prostate cancer or widely metastatic lung cancer is dying, and they insist that everything be done. And actually in my book I talk about how I still think I have post-traumatic stress disorder from what I did as a 28-year-old second-year resident to a man who had widely metastatic lung cancer, for whom the answer was, we need to try to keep him comfortable because he's dying. But we kept him alive for an additional 6 weeks. And finally, on the day that he died, I was sitting at his bed, at the foot of his bed, and I realized that he was on a ventilator. So this poor kid from Detroit, and this guy, it would be interesting to know what this guy would have thought of this if he had been able to think, because he was probably a redneck, and I was this poor kid from Detroit sitting at the foot of his bed deciding how much air he would breathe in with every breath, how often he would breathe it, what his respiratory rate would be. We had to put in a external pacer to his heart, so I was about to figure out what I wanted his heartbeat to be that day. And he was on Levophed and dopamine for blood pressure support, so I was about to figure out what I wanted his blood pressure to be that day. Just dial him up or dial him down to whatever we wanted. No quality of life for this. This guy lived this way for about a month, by the way, because his family could not accept the fact that he was dying. And what we should do is try to keep him comfortable. They continuously said, we need to give this guy everything possible. We would say, do you mean everything reasonable? And they would say, everything reasonable is everything possible. And that happens all the time and time again. It's probably happening down the street at Grady Hospital today, that people cannot accept that death is a part of life. Death is an imminent part of life. And so let's get back to how doctors promise people, and indeed many of these people can't accept that folks die because we in medicine have subtly lied to them over the years and thought that we can do much more in medicine than we actually can do. Many of us have exaggerated the benefits of things, prostate cancer screening. And by the way, the reason why I got so vocal in the prostate cancer screening discussion is, and by the way, for those of you who don't know, we started widespread prostate cancer screening in the United States in 1990. It was 2010 that the first study actually was reported that told us that prostate cancer screening might save lives. So we did it for 20 years because some people thought it might save lives. But we told people, we in medicine in general, told people it does save lives and you should get it. My own American Cancer Society recommended every man over 50 get prostate cancer screening, every black man over 40 back in 1992 without adequate scientific data. Of course, the study in 2010, which is still questionable as to whether it saves lives, but the study that actually suggests that it might, which was published with a study that suggests that prostate cancer screening actually increases risk of death, by the way. The one study that suggests that it might save lives said that we had to treat 48 men in order to save one life. By the way, prostate cancer treatment with radical prostatectomy in the United States has a 1% risk of death. You can kind of start doing the math. There's not a lot of people saved. But in any event, the reason I got into prostate cancer screening and got so outspoken was partly because of those folks I grew up with who were skeptical of medicine, and partly out of respect for them, and partly out of what had happened with the Tuskegee syphilis apology. A week after returning from Clinton's apology, and President Clinton apologized for the fact that a large number of people from the U.S. government, and by the way, some of those people who did the bad things were black people, and some of them were black people from Alabama, from Tuskegee, the Tuskegee area. They lied to a group of black men and their families about whether or not they were being treated for syphilis. Some men were actually lied about whether or not they had syphilis. The Tuskegee syphilis study was one of the first case control studies in which a group of people with the disease were compared to a group of people who were age matched who did not have the disease. So President Clinton apologizes for the fact that these men were lied to and misled for 40 years. A week later, I'm an assistant director at the National Cancer Institute, and I have to go out and visit a hospital. A hospital that is an NCI-designated cancer center. And there's the whole dog and pony show where they tell you how great the hospital is and how much service they do. This hospital chose to get their marketing guy out there. Vince Dollard is in the audience, isn't he? Vince Dollard's the marketing guy from Emory. I always like to pick on him. He's a guy like Vince Dollard. This guy explained to me how if his hospital announced they were going to do free prostate cancer screening in 6 weeks at a particular mall, and they would screen the first 1,000 men who rolled up their sleeve and said, please screen me, men over 50. He explained to me how much free publicity they would get off of that announcement and how much increased business their chest pain center would get off that announcement, how much increased business their breast screening service, their women's center, would get off that announcement. Eric is smiling because he knows the story. Well, then when they get to the screening that weekend at the mall, you see the mall has a certain demographic, and screening has this amazing thing. Uninsured men don't go to free screening. If they screen 1,000 men, they'll have 145 abnormals. They're going to charge about $3,000 to figure out why each of the 145 abnormals is abnormal, and that's how they pay for the free screening. Now, with this mall, about 10 of that 145 won't come to this hospital, so that's business for their competitors, but they'll get 135 times $3,500 on average. Now, the 135 that they have, 45 are going to have prostate cancer, and you know the percentage they're going to get radical prostatectomy at about $30,000 to $40,000 a case. The percentage they're going to get seeds at about $30,000 a case. The percentage they're going to get radiation therapy, IMRT radiation therapy at the time was about $60,000 to $70,000. And then his business plan goes further. He knew how many guys are going to have so much incontinence that diapers don't do it, so he had in his business plan how many artificial sphincters his urologists were going to implant. And then he was a little apologetic because there's this new thing called Viagra on the market, and that screwed up his estimate of how many penile implants he was going to sell because of guys who were upset about impotence due to prostate cancer treatment. The guy's talking to me. I said, if you screen 1,000 people, this is 1998, you screen 1,000 people, how many lives you going to save? He took his glasses off, looked at me like I was a fool, and he said, don't you know, nobody's ever shown that prostate cancer screening saves lives. I can't give you an estimate on that. A week after I returned from the apology at Tuskegee, I realized Tuskegee was with us in 1998. And all these folks, black folks especially, were being told, because prostate cancer kills people, you need to get screened. To this day, we have advertisements on radio talking about how prostate cancer screening increases survival By the way, they never say it decreases mortality. We've never proven that prostate cancer screening decreases mortality. So, truth in advertising requires a certain amount of education on the part of the consumer. Also requires a certain amount of education on the part of doctors. Quite honestly, a whole bunch of doctors have drank the Kool-Aid. They don't actually understand that prostate cancer screening may not save lives. The fact that some of them make money off of it helps them to not understand, of course, but what we need to do, as Father Polakowski used to say in ninth grade, you need to figure out what you know, what you don't know, and what you believe, and you need to label it accordingly. And unfortunately, doctors tend to confuse what they believe with what they know. And that's actually something that we docs need to work on. We also need to realize that a profession is a group of people who puts its customers and the welfare of its customers above the welfare of members of the profession. And a profession is a group of people who polices itself. That's one of the reasons why when a group of doctor professional organizations a couple of weeks ago announced these are tests that we are overdoing and we need to stop doing so often, I actually thought that was a good thing. We're starting to finally realize what the real meaning of the word profession is. Now, there's so many stories about waste. You heard those stories with the various awards that were given earlier. So many stories about how we totally ignore science. I already told you we did prostate cancer screening without a study showing that it might save lives for 20 years. The bone marrow transplant story in breast cancer is just as bad. Actually, that shows you how a lot of folks can get involved in the practicing bad science. In the mid-1980s, it was thought that women who had breast cancer would do better if we could give them higher doses of chemotherapy, especially women who had localized or local regional breast cancer, where it was all surgically removed, but there was still probably some cancer in their body that we couldn't see on CT scan or X-ray or so forth. We give them high doses of chemotherapy and maybe kill that cancer that's not there. Well, the problem was our drugs are pretty potent and pretty awful, and they actually knock out the bone marrow. And so we came up with this idea called autologous bone marrow transplant. We take the woman's bone marrow, put it in a freezer, give her chemotherapy at high dose. What bone marrow is left behind gets blown away by the chemotherapy. That's not a medical term. And then after the chemotherapy clears out of her body, we take her bone marrow out of the freezer, thaw it out, and we give her her bone marrow back. And it reimplants about a week to a week and a half later, and it starts making red cells and white cells and other things. And but her cancer that may be there that we can't see, got exposed to all that chemotherapy and hopefully died. Well, it's a great theory. The Otis Brawleys of the late 1980s said, let's do a study to figure out if it works. The folks who wanted to make money said, why don't we just do it? Indeed, in 1999, the year 4 clinical studies were published to show that it net killed women instead of benefited women. There were more than 220 bone marrow transplant breast cancer centers in the United States that were doing bone marrow transplant on 60,000 women per year. The 4 studies showed that it increased risk of death by about 5% to get bone marrow transplant. Now, along the way, Numerous women sued their insurance companies in the early 1990s because they wanted this new bone marrow transplant. It must be better. It's a new thing. We want it. You're a bad insurance company because you don't want to pay for it because there's no evidence that it works. Many of those women won their lawsuits. Indeed, today, there are 11 states in the United States where the law says that insurance companies must pay for bone marrow transplant because the 11 state legislatures and 11 governors passed laws saying that the insurance companies had to pay for this stuff in the early 1990s. They never got around to repealing those laws. This is how we practice an irrational form of medicine. When I hear the politicians talk about death panels and rationing, we need to be talking about rational use of medicine. Not rationing, but rational. And unfortunately, that's not happening in the United States. There's also, let's pick on a drug company for a second. I hope AstraZeneca doesn't sponsor you guys. There's this drug called Prilosec. Suppresses acid in the stomach. Great drug. AstraZeneca only had one problem. 18-year patent. 4 years left on the patent. $5 billion a year drug. Lots of money made off of Prilosec. What's going to be our next multi-billion-dollar drug? Well, they started this thing called Operation Shark Fin. The search for the next multi-billion-dollar drug. You know the story. They couldn't find a new drug, but they found a very smart chemist who knew a little bit of patent law. You see, Prilosec, when it is made, is a big molecule, and not to get it too much into the chemistry, there's really two chemicals there, and they're mirror image isomers. Just like your hands are mirror images of each other, and they actually, in chemistry, call them left and right. Well, when you have a pill of Prilosec, the left suppresses acid, the right, your liver takes out, sends it to the kidney, and you urinate it out. But it's the left that's active. Well, this smart chemist realized it's just one quick, easy chemical step in the lab to do what your liver does for you, separate left from right. And so they separated left from right. They did a series of studies that they sent to the FDA arguing that this new drug, which we have patented, called omeprazole, is equivalent to the old drug. And the FDA agreed that the new drug was equivalent to the old drug, so the FDA approved it. It's equivalent in side effects, it's equivalent in efficacy. And then they went to their marketing guys. Vince, you in the room again? They went to their marketing guys, and they said, how are we going to market this drug, the next multi-billion-dollar drug for AstraZeneca? And the marketing guys said, we're going to package it as a big purple pill. And then they said, what are we going to call our next multi-billion-dollar drug? They said, let's screw them. Let's call it Nexium. Okay? Now, I happened to go to Costco yesterday. A pill of Nexium is $6. A pill of Prilosec is $1, and a pill of generic Prilosec is 35 cents. Okay? Now, one of the 10 most prescribed drugs in the United States today is Nexium at $6 a day. But all the science tells us it was FDA approved because it's equivalent to something that costs 35 cents a day. And we wonder why we have 18% of our GDP going toward health care, you see. By the way, about $8,000 per man, woman, and child is what health care costs in the United States today. The number 2 country, which is Switzerland, is a little less than $4,000. Switzerland is 4th among UN countries in life expectancy, and we're 50th. I don't think we get what we pay for. Now, when you look at per capita costs, you know, I am an executive in a company that actually employs several thousand people. Our average cost for health care is almost $19,000 per employee. That's a family health care plan. Those of you who actually run organizations can tell you the average cost for us to insure a employee on a family plan now is between $18,000 and $20,000 per family, and the average cost of health care in the U.S. is $8,000 per person. Now, we have employees, clerks, who get paid $30,000 a year, and their health care insurance costs $18,000 a year. Now, we talk about commerce in the Commerce Clause. It seems to me that the high cost of Nexium and health care is actually impeding our economy. If health care costs $8,000 a family instead of $18,000 to $19,000 a family, many employers would be hiring more people. You see, what we need to do, and what we desperately need to do, is not reform health care. We need to transform how we view health care. We need to become much more appreciative of prevention efforts and health care prevention efforts. We need to reimburse doctors who coach and talk to patients far better than we are. Today, we give doctors who do interventions in patients a lot more money than they should be getting, and doctors who talk to patients very little money. The incentive on the doctor today is to not talk to patients, just move them in, move them out, and get volume. We need to understand and appreciate science. We're not going to have improvements in our healthcare system until the mass population demands that doctors appreciate science, demands and asks doctors to justify their recommendations and justify their decisions. We need the skeptical, educated consumer. We need people who consume medicine to think about healthcare the same way they think about buying a television set at a Best Buy. We need people to actually stop just accepting things and start being skeptical. And this is why you guys are really important to me. Ivan, the reason why I take time to talk to people in the press is you guys are really important in terms of getting the word out, in terms of educating the consumer, in terms of educating the populace. I know you guys have had a very hard time. Some of my best friends have been laid off. But I want to tell you, these awards that I saw today tells me that you guys are still doing great work. I know how hard it can be to work in an industry that's under assault. So I'm going to stop at this point by just saying thank you and saluting you guys for all the wonderful, good work that you guys do. Thank you. Oh, you're too nice. You're too nice. Thank you so much.
I just want to ask, we do have time for questions. There are mics, just so that everyone can hear, and so if you could just walk to them. There's one over there and one over there. Dr. Brawley certainly has time for questions.
Thank you. Thank you, guys. You're wonderful. Yes, ma'am?
Yeah, thank you, Dr. Brawley.
Everybody calls me Otis, by the way.
Oh, I'm sorry. Call you Otis. I appreciate your conversation, your speech. I'm a journalist from Oregon. I'm also proud to be a 16-year breast cancer survivor. And my question to you is, thank you. I understand you're responsible for promoting cancer prevention. Why has the American Cancer Society been so reluctant to acknowledge the link between environmental exposures that have been documented by scientists such as Sandra Steingraber, and the link to cancer?
The biggest environmental promoter of cancer actually is diet and lack of exercise. So we have to spend, I think we need to spend most of our efforts on that. Some of the data on environmental causes of cancer, really when you start peering through it, doesn't pass a bunch of tests. For example, I'm still convinced that DDT causes some cancers, but the truth be told, every time we have done a study to try to prove it, we've been unable to prove it. And so I'm at a loss as to what we should do about DDT, because I believe that DDT causes cancer, but I'm at the point that I don't know that it does. And so I struggle on a daily basis with environmental causes of cancer. I struggle against some of the garbage. For example, in cell phones, much of the data on cell phones causing brain tumors is generated by about 8 people who really believe that cell phones cause brain tumors. Now, that doesn't mean that cell phones don't cause brain tumors, but growing up where I grew up, that increases my suspicion and my scrutiny of the literature. And the answer on cell phones, again, is I don't know. I guess what you're starting to see, and we started with screening, and a few people before the luncheon were talking about how when you start changing an industry, you can't turn it on a dime. It's not even like changing the direction of an aircraft carrier. We will get a little bit more open and honest about the science, but we're also going to get more rigorous and religious to the science. Yes, ma'am?
Hi, I'm Peggy Gershman from Kaiser Health News. What do you make of the decision of Medicare to cover Avastin for breast cancer? Thanks.
Avastin is a difficult issue. Let me just tell you what I think about Avastin. I think there is a group of women who Avastin is a very good drug for, and there's a group of women that Avastin literally kills. And the women for whom Avastin is a very good drug, they show up at hearings of the FDA and other things, and they give interviews. The women killed by Avastin you never hear from. I think we desperately need a marker or a way of saying this is a woman who will benefit from Avastin, this is a woman who won't. I will salute Genentech because I've seen drugs in the past where a drug company tried to suppress a test because they knew it only was good for 30% of cancer patients with a particular disease, and they would suppress a test to identify that 30% because they wanted the whole market of lung cancer patients instead of the 30% who would benefit from their particular drug. Genentech has not done that, and Genentech has encouraged development of that marker. I have tremendous difficulty. I'm going to answer your question and not give you a Washington answer. I have tremendous difficulty in telling a woman who wants Avastin, who truly does understand that it kills people and it may actually be more likely to kill than to help. I have difficulty depriving a woman who truly understands that of that drug. That's not the reason for the health care excess costs in the United States. The reasons for the excess health care costs are excess use of things that we know we don't need. Yes, ma'am?
My name's Eileen Beal. I'm a freelance, mostly geriatrics writer from Cleveland, Ohio. And actually, my question follows right up on what you just said. There are 30, 50, in some cases maybe 70% of tests that we don't need. And we think of this as just tests. But there are technicians and doctors and nurses and allied health professionals who are allied health professionals who provide these tests. And if you're going to cut the test, you're going to cut their jobs too. What kind of discussion is going on among people like you about the fact that if we move to a more quote-unquote rational, and I really believe we need to move in a rational direction, what do we do about all the jobs lost, about all the professionals lost, about the shrinking body of people with good paying jobs?
Well, there's a little, I went to the University of Chicago, and a little bit of University of Chicago economics rubbed off on me. they'll find other things to do, and we'll become a much more productive society when they are not doing make work. That's my belief. Yes, ma'am.
Lola Butcher, Oncology Times. You mentioned the Choosing Wisely campaign. I'm interested the top 5 list that the American Society for Clinical Oncology published. How's that going to affect oncology care in America, in your opinion?
I am hopeful that ASCO, the American Society for Clinical Oncology, has enough influence that doctors actually start listening to that. It is actually going to decrease some oncologists' income. The imaging recommendations will decrease some radiation oncologists' income, which may be somewhat appropriate. By the way, while I have the fact in my head, it's actually in the book. When we talk about imaging in the United States, on a per 100,000 person basis, we have 3 times as many CT scanners and 5 times as many MRI scanners as in Canada. Canada is 10th in life expectancy, and we're 50th, despite the fact that we criticize Canadian healthcare all the time. And I'm looking at Sabria now because she told me just as I came up here, remember, everything is on the record. I'll go on the record and say, people in the United States may not live longer, but we sure as hell do a much better job of taking pictures of them dying. And so, in any event, I do think that the ASCO thing is a good recommendation. It will decrease income for doctors, and that may be a good thing overall at some point. Can't believe I just said that. Yes, ma'am.
I'm Irene Woloski, an independent journalist from New York. I'd like to take you back to the autologous bone marrow transplant for women. I happened to be covering such a case at the time. It was very wrenching. It was a young mother with young children, devoted husband, and she was dying in a sealed unit in a major teaching hospital. And I was very moved by her plight, and her insurance company wouldn't pay for it. But I also had an ongoing dialogue with the medical director of that insurance company, who was opening up all of the scientific evidence to me, and it was not persuasive. So my question is, what do you think about the role of insurance companies today and then? It really was a break on the industrialization of autologous bone marrow transplant with no underlying science.
Yeah.
And today we see insurance companies doing more of this with My Cigna, My United Healthcare, an attempt to communicate directly with the covered patient about health and about parameters of treatment.
Yeah, insurance companies are an interesting entity. Their 20% profits do disturb me a little bit. They do have some ability to make us better in practicing medicine. I know in a patient that I see, I happen to give metformin to because she was a diabetic and she was getting metformin from her primary care doc, and she needed a renewal of the script, so I just renewed the script as a favor to her. And I got a letter from her insurance company noting that she was not on any of the ACE inhibitors that diabetics frequently are put on to protect their kidneys. I actually thought that was a pretty good idea, that the insurance company is monitoring what drugs they're actually paying for and saying, hey, this lady is on this drug, she ought to be on this other drug as well. I thought that was a pretty good thing. But in my book, How We Do Harm, which is available, anyway, in my book, I actually talk about a lady who lived in a suburb of Atlanta, and one of her cousins got me involved in her health care. I spent a lot of time talking to people about their disease or helping them find the right doctors. This lady was convinced that even though she had stage 1 colon cancer, she needed adjuvant chemotherapy. Despite the fact every medical oncologist that she went to asking for this chemotherapy told her that there was no science to show it would help her, There was science to show it would help someone who's 2 stages higher than her. The study had been done on somebody who was on people who were 1 stage higher than her, and that study showed that the chemotherapy didn't help. They said giving her chemotherapy would do one thing, give her side effects, really 2 things, give her side effects now and side effects later. Her risk of having leukemia 10 to 20 years later would be increased because of the chemotherapy. But she wanted the chemotherapy to the point that one of the 4 medical oncologists who told her she shouldn't get chemotherapy ultimately gave it to her. Now he, of course, got about $6,000 to $10,000 for the 6 months of chemotherapy, and she ended up raising her risk of leukemia and got no cancer benefit. Now, why did her insurance company pay for her to get this chemotherapy she didn't need? Well, it turns out that the HIPAA law allows the insurance company to know she had colon cancer, but does not allow the insurance company to know she had stage 1 colon cancer. So the HIPAA law does not allow her insurance company to know that she was getting chemotherapy that she didn't need, because it doesn't allow them to know her stage. I think that's stupid. Yes?
Bob Rosenblatt, freelance writer. Do you think that Warren Buffett, who is 81, got bad medical advice when he was told to get radiation for his stage 1 prostate cancer?
Well, I'll back up a little bit. No organization currently recommends that men just get screened for prostate cancer. The U.S. Preventive Services Task Force has floated a proposed recommendation that they recommend against all men being screened for prostate cancer, but the one that was issued 5-6 years ago says no man over 75 should be screened for prostate cancer. The American Urological Association and the American Cancer Society, in different wording, say that if a man has a greater than 10-year life expectancy, understands the potential risks and the potential benefits of screening, and wants screening, he should get screened. Now, I don't know anything about his full health. I don't know, maybe he has a 10-year life expectancy, and maybe he was informed. But those are the only organizations that would have said that an 81 or 82-year-old should be screened. You know, if his father lived to be 100, maybe that's appropriate. Now, for men who are 82 who have stage 1 prostate cancer, most of those men, in my mind, should be observed. There are a few of those men who have high Gleason score disease who I would recommend they consider getting radiation. That's the best I can answer your question. Most 82-year-olds, I would recommend they be observed, but there are a small number of 82-year-olds with stage 1 disease who have certain features that we don't know about that I would recommend that they get radiation. For you guys over there, I was just asked, should Warren Buffett pay a higher tax rate? Next.
Hi, I'm Grace Rubenstein with the Sacramento Bee, and I did a story a few months ago about the HPV vaccine, after which I got the usual emails from vaccine haters, which I usually ignore, but I got one from a man who pointed out that the big study that Merck did that was the basis of the FDA approval for the vaccine indicated that this vaccine greatly reduces your risk of the lesions that precede cervical cancer.
Yeah.
But it's being billed as a vaccine that prevents cervical cancer, which actually would probably take decades to prove.
Right.
And shucks, he was right about that. So I'm just interested in your thoughts on that, and if it is the case that cervical cancer prevention is just something we believe, is it still appropriate to be giving this vaccine so widely?
Yeah, I do think it's appropriate to be giving the HPV vaccine. By the way, I believe it prevents head and neck cancer as well as cervical cancer and some vulvar and genital cancers and penile cancer for that matter. What you just said is absolutely correct. And we are assuming that all cervical cancer comes through these preneoplastic lesions that this thing prevents. And so I think HPV is a good thing, but I think that we have, like in many things that we have done, we have sort of overstated the case.
Laurie Stoneham, dailyrx.com. What do you think about the problems that are being found with various cancer standard of care therapies, including radiation and its promotion of stem cells, which are resistant to radiation, and also a growing thought about chemotherapy actually damaging healthy DNA, which could promote later cancers?
Yeah, I think all the more reason that all these things need to be done through very good clinical trials. The chemotherapy stuff, we really need to do long-term follow-up. I was trained at the National Cancer Institute, and a lot of the stuff about adriamycin causing cancers 10 years after treatment came only because some of the folks who had lymphoma who did very well were brought back to the NCI every year in follow-up, and they started seeing 10 to 15 years out. There was leukemias as well as some, with some of the cyclophosphamide-treated and ifosfamide-treated patients, bladder cancers. So I think that long-term follow-up is very important. I do think we need to be cautious in our advocacy and our use of these chemotherapy drugs. By the way, one of the big new things that everybody's concerned about is nurses and pharmacists who mix these drugs actually developing cancers because of their exposures.
I think we have time for maybe one more question from each microphone. Sorry, we're running out of time.
Hi.
The rest of you guys, I'll stick around in the corner if you want. Yes, ma'am.
Okay, I'll try to make this brief. Hi, I'm Vivian Felagi. I am a former family doctor from Toronto and also freelance medical journalist. I've written a couple of times for the Medical Post, which is Canada's magazine for doctors. In my work as a doctor, which I've now quit, I did have the privilege of being present at a very good death. My question is this. I'd like to write an article inspired by your wonderful talk. I think doctors, from my experience, can be put in an impossible situation. You know your patient's a goner. Your conscience says, let him go, but their family wants everything to be done for them. I have two questions for you. Number one, can I quote you for an article I'd like to submit to the Medical Post?
Sure. Everything I
Super.
said here is on the record.
Awesome. Number two, they may want a Canadian doctor because it's a Canadian news.
Yeah,
Do you have a counterpart who'd be willing to talk to me about the similar?
Some of my best friends are Canadian.
We'll talk.
Hi, I'm Matt Perry. I'm a freelancer in Sacramento. A few months ago, I sat in a room in Sacramento, much like this one, healthcare conference, and Peter Lee, who was the head of the exchange in California, said to the audience, if you don't feel like this is one of the best times to revolutionize healthcare, you should think of another profession. And the rest of the day was devoted to the same old discussions. And so I was kind of wondering when the healthiest people in the country would be involved in revolutionizing the healthcare business, meaning people like the fitness instructors, the dietitians, the people who address the issues that you mentioned, the biggest environmental causes of cancer being poor diet and poor exercise. Thank you.
I think you're exactly on target, and one of the things that we were privileged to do is help the First Lady out with her Let's Move campaign, and you would be amazed. Yeah, she deserves a book. You would be amazed how much criticism they have gotten for Let's Move. Unfortunately, our greatest problem is there are a group of people, and I'm criticizing both sides of the aisle here. If one side of the aisle says the sun is shining and it is 12 noon, the other side will argue that fact. And that is just so detrimental, especially when you're talking about kids and obesity and so forth. By the way, I will tell you that the greatest problem with obesity is 4% of America's kids aged 6 to 11 were obese in 1980, and in 2008 it was 20%. It had increased by a factor of 5 among kids aged 6 to 11 from 1970 to 2008. Now the reason why that's important is, I'm a very orthodox conservative scientist. I got a couple of studies that suggest that if we do gastric bypass surgery and bring people from a body mass index of 45 to a body mass index of 35, we lower their risk of getting cancer by a little bit over 15 to 20 years. I got lots of data that tells me getting fat causes cancer. I got very little data, I just quoted all of it to you, that tells me that getting skinny reduces risk of cancer. Okay? So the smart thing here to do is to prevent kids from getting fat, as opposed to taking 50-year-olds and putting them on Weight Watchers. Okay? Now, that's my excuse, okay?